Hi, everyone. Welcome. Happy New Year for those of you that didn't make it last time. So 2024, wow, that happened fast. And we are excited to have Erin, Henderson, Lacerdo, and Anne-Marie Cline from AIM-High talk to us about infant mental health today. We were chatting a little bit before we got started, and I was so happy to hear that they really want to give everybody like a solid overview / refresher for a few of you who might have been here a couple years ago when we did talk about infant mental health in the past. But really focus on practical aspects of how to make sure to support parents and young children in those really difficult times of transition through infancy into toddlerhood. So without further ado, I'm going to go ahead and just remind you that I'll be monitoring the chat. If there's sort of like clarification questions in the moment, I will probably interrupt to just make sure that we're all on the same page. For bigger picture questions or any cases that you might want to discuss afterwards, we'll go ahead and save those till the end. So welcome, Erin and Anne-Marie. Thank you so much. And I'll go ahead and mute myself and be taking care of the chat from now on. Thanks.
All right, aloha everyone. Happy lunch hour for many of you, I'm sure. My name is Erin, and Anne-Marie is my co-presenter today. And we're really excited to be able to talk to you about infant and early childhood mental health. And so I'm going to share my screen so that we can follow along. Okay. And hopefully, if you were able to join us a few years ago, that there are some pieces that might be new to you or some piece of information that might be helpful for you in your practice. Okay, so let's see. We do need to add a disclosure. I know that Summer already said so, but we're just going to reiterate that we don't have any financial or other conflict of interest in relationship to this presentation. And I just wanted to share a little bit about AIM-High, and the way that we describe ourselves is really that we're the hands that hold the hands of those who hold babies. And when we think about the work that we're doing, right, our mission really is to, or our vision, I should say, is that infant and early childhood mental health is everyone's kuleana. And so all of us have a role to play in the life and the mental health and the development of that mental health of young children across our state. And especially for our pediatricians and our medical field, families come to you guys very frequently and you are trusted partners with them. And so we do hope that you'll see yourself as part of the team. If you don't already, see yourself as part of the team of those who help to promote healthy infant and early childhood mental health developing. So today we're hoping to do about 3 main things. And one is to give that overview, explanation, and define infant mental health. And then also find a few ways that might be helpful for you to implement in your practice, as well as just really highlighting the importance of collaboration with community partners and how we can all work together as a community to serve the families. So I hope that you will entertain us with getting to know you a little bit better. And we are going to be doing a Mentimeter. So hopefully you're able to participate. And a Mentimeter is, if you have not used one before, I'll switch slides in a second, but we'll be able to see in real time what your responses are. So Anne-Marie is putting it in the chat, a link that you can go to. And if you prefer, you could also use your cell phone if you have that handy and use the QR code to open it on your device. So the question that we have is just to help us get to know you a little better. And what is your title or position at work? And if perhaps you are here like on a personal basis, maybe that might be something that you can indicate also, like what is your, how can we help to know better who's in the room with us? We have 2 questions for you today. All right, lovely. So we have some coordinators. So the bigger the bigger the word, the more people have responded with that answer. So that's how we know that there's more people who are in that coordinator role, with program managers, social workers, care coordinators, pediatrician. I think the social worker got split up, but so we have some social workers, some PHNs, nurse practitioners. Thank you so much for letting us know a little bit more about you. And so, and thank you, Janelle. I see in the chat, a social worker interested in learning more about infants. Thank you. Okay, so we do have another question, and what we would like to know, we're curious with you, how would you finish this sentence? How would you finish this sentence? Infant and early childhood mental health is ... I'll give you guys a little bit of time to respond, since it's an open-ended question. Let's think through, what is infant and early childhood mental health? What do we think so already? Thank you, Renata, always in development. Lovely, I see some people responding already. Crucial and healthy development, yes, and an important foundation to build with love and care. Okay, I'm wondering if some are maybe not sure what to answer here or what to respond with. And that's great, because then we can talk about that today. So yes, important in the development of children. Absolutely. Okay. Thank you for those of you who were able to stick something in there. And if you're still thinking of something and maybe didn't quite get a chance to put it in the Mentimeter, please feel free to put it in the chat box for us. As we explore today, what is infant and early childhood mental health?
There are a couple in the chat box. Sorry to interrupt.
No.
But one says always in development, and the other says the basis for developing healthy adults, adolescents, and adults.
Yes, thank you for that last one. That I didn't see that one till just now. Thank you, Maya, Dr. Maxim. And that's really what it is, right? We're really talking about this changing the trajectory of lives and starting as early as possible. So thank you for seeing the connection to the long game. All right.
All right, so we're gonna do a quick overview to kind of get us started of what mental health is. And I'm sure a lot of you are already familiar with this, so a little bit of review. But sort of a broad view of what mental health is that it's something that we all have. We all have mental health, but we don't all have mental illness. Mental health is not mental illness, though I think sometimes those terms can be used interchangeably in some ways, and so it can get confusing. But everyone has varying levels of health and varying levels of mental health. We all have emotional and psychological states that carry along a spectrum. And some definitions we have here from the World Health Organization states that mental health is a state of mental well-being that enables people to cope with the stresses of life, realize their abilities, learn well, and work well, and contribute to their community. So the ability to cope well with life as it comes up, right? And then the CDC states that mental health includes our emotional, psychological, and social well-being, and it affects how we think, feel, and act. It also helps determine how we handle stress, relate to others, and how we make healthy choices. So although, like I stated earlier, these terms are often used interchangeably, poor mental health and mental illness are not the same. A person can experience poor mental health and not be diagnosed with a mental illness. And likewise, a person who is diagnosed with a mental illness can experience periods of feeling well and able to cope with stressors in a positive way, depending on what's going on in their life. So for example, we all experience sadness, grief, frustration, these various feelings at one point in our life, but that doesn't mean that we all have major depressive disorder. Those can just be life experiences. We can all experience anxiety, but that doesn't mean we have generalized anxiety disorder. Mood swings don't mean we have bipolar disorder. So it depends on the extent in which it impacts your life, right? Whether it's mental health or mental illness. So next, we want to talk a little bit more about then focusing specifically on defining infant mental health. So it has these different components, social emotional health and infant mental health. We want to start by setting the stage for a concept that we want to cover. Many times social emotional development and infant mental health are said to be interchangeable. However, a key difference between the two is that with infant mental health, the relationship is the mechanism for the development. So the caregiver, the family, the teacher, all these people that surround this infant, it's relationship-based work is really what we focus on and how much that impacts the baby and always keeping that baby in mind and that the mental health of the caregiver is going to directly impact the mental health of the baby. So the baby develops in the context of this relationship, and that is the most critical thing to remember. Social emotional development includes milestones and markers, as I'm sure some of you are familiar with, and the way in which we describe what's happening for the baby. So infant mental health is this recognition that babies do in fact have mental health, and that mental health is dependent on the relationship they have with their caregiver. And if whether or not we're considering their mental health as a part of their development and what that looks like. So for social emotional health, this is from 0 to 3 defines it as within the context of one's family, community, and cultural background. Social and emotional health is the child's developing capacity to form secure relationships, those first relationships that we are going to speak a lot about, experience how to regulate their emotions and how to explore and learn. And then the Alliance for the Advancement of Infant Mental Health defines infant mental health as the optimal social, emotional, and cognitive well-being of children ages 0 to 3, developed by secure and stable relationships with nurturing caregivers in their lives.
And so there are many infant mental health years. Thank you, Renata, for the clarification, 0 to 3 in years. So when we say infant, that's defined in the context that we're speaking of as 0 to 3. When we say early childhood, we're referring to that 3 to 5 age range. I know that I was talking, I think Anne-Maria, you and I were talking about like how different people may categorize early childhood in different ways. And so just to clarify for us today, we are referring to that 0 to 5 age range in particular. Although, of course, I think that it expands quite past that in terms of like the premises that we're talking about, but the specific age range in terms of child development would be 0 to 5. All right. So while there are many infant mental health principles, there are a few that are really foundational to infant mental health work or framework, I should say. And so we're going to talk about 3 of those today, and hopefully these will be provide you with some strategies or ideas that you might be able to integrate into the work that you're doing. So these 3, and we're going to go into each into detail, so I'll just name them here. So one is the parallel process. The second is keeping the baby in mind. And the third is process versus product or content, which also means processes matter.
All right, let's get started with principle 1, the parallel process. So this phrase was originally coined by Carl Jung, and it's the idea that we as human beings can find similarities between our lives, our patients, and simple awareness of this can go a long way in helping us realize how we may be viewing a situation from our own lens due to past experiences, or maybe not looking at it from the current situation of what's happening. Another example of kind of this parallel process is that the relationship between the medical professional, the social worker, the caregiver, and the patient may mirror the relationship between the caregiver and the baby and the way they communicate and interact with each other. Did you want to add anything to that, Erin?
No.
Okay. We talk about parallel process a lot. It's a hot topic in our office. Okay. So we also want to talk about some theories that support and back infant mental health. So we're just going to briefly go over them today. And if you have any interest, we can definitely send more information on them later. So there's many theories that support or scaffold the practice of infant mental health. They all intertwine together to form a perspective that places the relationship that we've been talking about as the central agent of change. The first one I'll talk about is attachment theory. which was developed by John Bowlby. Attachment theory emphasizes the importance of secure emotional bonds between infants and their caregivers. Again, going back to that relationship. This suggests that infants develop an internal working model of relationships based on that relationship and bond with their caregiver. And that can then influence later in life. I'm sure we've all heard all those tests we can take about what kind of attachment style we have and how that impacts our adult relationship as well. So this is kind of the very start of that with their first relationship with their caregiver. Another one is social emotional development theory. This is proposed by Erik Erikson, and this theory emphasizes the importance of the social and emotional environment in shaping an infant's development. So what surrounds them. This suggests that infants go through different stages of psychosocial development where they develop trust, autonomy, initiative, and other important social emotional skills. And we have to know how children develop in order to support them and work with them, in order to meet them at their level and meet them where they're at. It's helpful to know what developmental stage are they at so we know how to reach them best, yeah? And then we have maternal mentalization theory. This theory was proposed by Peter Fonagy, hopefully I said that name right, focuses on the importance of a mother's ability to understand her infant's mental states and respond empathetically. So to be able to be in tune with her child. Maternal mentalization contributes to the development of the infant's sense of self and also their ability to understand others' emotions. So develop their own empathy and read cues from other people around them. And then we have neurodevelopmental theories. These theories highlight the critical period of early brain development and its influence on infant mental health. And then next up, we have ecological systems theory, developed by Yuri Bronfenbrenner. That's a long one, but I got it, I think. This theory emphasizes the influence of various environmental systems on infant mental health, so somewhat similar to Erik Erikson in that sense. And this one suggests that infants are affected by interactions with their immediate family, with their community, their culture and society, and that this all plays a role in their development. So it's not only always that relationship with the caregiver, but all of the relationships that impact this little one's life. And then last but definitely not least, we have trauma and resilience theories. And we can't talk about humans without talking about the trauma and resilience and different experiences that we've all had in life and how this changes the body, the brain, and the relationships that we have and the way we respond to different stressors in life, triggers, emotional reactions. These theories focus on the impact of adverse experiences, such as abuse, neglect, possible exposure to violence, and how this affects infant mental health. They really explore trauma and how it impacts the child's emotional well-being. And like I said before, if any of you want to dive deeper into these theories, we're just giving a brief overview. We're happy to send more information to you.
And so this parallel process, right, as you heard in so many of the examples that of the theories that are the underpinnings of infant and early childhood mental health that Anne-Marie just shared, all of them have the baby in a relationship with someone else, right? That this baby is not developing on their own, that the baby is in fact impacted and supported by those around the baby. And so we like to think of the baby as in the center, and the people around the baby and the supports around the baby are kind of like these circles that are moving outward. And if you're familiar with Bronfenbrenner, he's very, he likes the circles. And so do we. We like the circles. It helps us to conceptualize cases and kind of help us to think through some approaches and strategies. And if you see on the right here, that's one of the more common toys, I think, that babies tend to have, which are stacking cups. And I like to think of the baby as being this top yellow cup here, that small one, the one the baby's actually holding. And it's really that smallest one in the middle. And when they're turned upside down, as opposed to being stacked, and when they're nested together, right, that baby sits in the bigger cup. And that cup would be like its primary caregiver, for example. Then that caregiver sits in another cup, right, which is then holding that caregiver. So what is the context of that caregiver's world? And then that family system, right, is then being held by the community or the providers that care for them. And so each one of these cups have a role to play in the life of this family and this child. And when they work together, or when, I'm not going to say put in the right order, but when they work together it creates a nice, stable environment for that baby in the center. Right. And so this parallel process can really help us to understand and conceptualize how big policymaking decisions can actually impact what's happening in the lives of babies on a daily basis. And to recognize that all of these things impact one another, and therefore will always impact the baby in the middle. So that's one principle that we hope that we can keep in mind. And so that brings us to some practical strategies. If you see on the left, there is a quote, "Do unto others as you would have others do unto others." And that is Jerry Paul. She's one of the grandmothers of infant mental health. And she called it the platinum rule, which is a little different from the golden rule, right? It's not quite it's just a little bit different of recognizing that we want to impact others and care for them in a very loving and caring way. So here are some examples. I'm colleagues with a pediatrician based on the continent, but who's focused a lot of her work in infant mental health. Her name is Dr. Sherry Alderman, and she helped to create some questions that might be helpful for integrating infant mental health into some clinical practice. So one of the things is to create clear messaging among staff that expresses the value that each person brings to the care of young infants, young children, and families, and how that role conveys that care at every encounter. So if you notice, that's all staff, right? That's the medical team, that's the administrative team, that's everyone who comes into contact with the family, and how they can express that value to the families as they're entering into the practice or into the office. Also, there's something that we kind of call like a journey mapping, for example, is kind of the term that we use of like, what is the journey of the client or the patient in your care? What is their experience, right? Can you walk that journey with them and see along the different ways, right? What is it like in the parking lot? What is that experience like? I have to go to a pediatrician, and sometimes I have to catch the elevator, and sometimes that's really stressful for moms with car seats and little babies and all kinds of things. So sometimes that experience can be stressful, and the parent might be stressed out prior to even entering the practice, right? So what is that experience of that family? Just so that we have better understanding and empathy for what their experience might be. So there are different touch points, right? We might be able to identify the different points at which the team can then communicate that care and value to the patient. And so reflection question, one of the real hallmarks of infant and early childhood mental health is this reflective practice. And so we'll be asking you a few questions throughout this presentation, not for you to answer unless you would like to, but just for you to ponder and reflect and to think. So the question is, what routine interactions with others might be an opportunity for a micro moment of positive shared affect? So we call these genuine encounter moments, right? Where can we have these moments of shared positive affect? Okay. All right. We'll move on here to principle number 2.
All right, principle number 2, keeping the baby in mind. That's something we say often in the infant mental health world to kind of recognize and revisit what is the baby's experience in all this. So in infant mental health, we aim to keep the baby in mind and always consider their experience while they're in our care. So just like Erin was saying, we have questions for you guys today. So to start off this principle, have a couple more questions just to keep in mind. And always feel free to add something in the chat if you want to share anything that comes up for you when we ask these questions. But like Erin was saying, you don't have to. So things we might ask ourselves when we have a baby in our care is, what might they be experiencing throughout our time spent with them? What might this look like through their lens? And how might we make a positive impact and support this family? All right, so we're going to watch a quick video about the still face experiment. Developmental psychologist Edward Tronick, a colleague of Dr. Brazelton, spent most of his career studying infants. His famous still face experience, which some of you may be familiar with, and maybe you've seen this video before, so it might be a review, but I think it's so well done and fascinating. It's always good to see again. But he tested this in the 1970s and provides us with tangible, concrete evidence of the critical nature of the relationship between caregiver and child. So let's take a look and see how he explains this.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm my girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
I would imagine that that was probably really hard for the mom in that video to just not respond to her baby, but I think that's a really great example of how impacted babies are from their caregivers. And imagine if a mother is experiencing mental illness such as depression or postpartum depression, and maybe she's unable to really respond as much because she's battling mental illness at that time, and just this idea that the caregiver's mental health and the baby's mental health are inextricably intertwined. I think that's kind of a good example of that too.
Thank you. And I've watched that video so many times, and every single time it just brings up so much feelings for myself just watching that poor baby. And I think of how that baby's responses, when we watch his experiment, we think, of course you're responding that way. Of course you're shrieking. Of course you're turning away. But sometimes when families come into whatever setting it might be, they don't always connect all those pieces together and don't recognize that some of the behaviors or things that they're seeing might actually be related to the way that the baby's experiencing their life. And so hopefully that video can just give you some tangible, visceral even feeling of what that must be like for that little one. So we talk about keeping the baby in mind. There's Dr. Winnicott, he said, there's no such thing as just a baby. There's a baby and someone. And so as we shared earlier, right, the framework behind infant mental health is recognizing that the baby is really important. If we care about taking care of babies, we have to care about the adults in their lives who care for them as well. And so it's really important, right? Family engagement is really important in the conversation at every encounter, right? Can we reflect, observe, and elicit information from the family about their baby's experience? What else might we do to learn more about how regulating or dysregulating the clinic environment might be? Families comfortable? Are they uncomfortable? Are staff comfortable? Because if staff are uncomfortable, then that might make it a different environment that the family is entering into. Another strategy is to perhaps look up some YouTube videos and just see, kind of like there's actually quite a few videos out there on the still face experiment and different examples, but different ways. One of the things that we want to highlight is really attunement, positive interactions, and then also other ways to just bring laughter and warmth into your own staff or team meetings as well. And so in reflection, when have you seen positive parent-child or caregiver-child interactions? And then putting yourself into that child's perspective. If you were that child, what is it about that interaction that made that interaction possible, that made that positive, shining moment happen? What is that child's experience? And so as we, our hope with keeping the baby in mind is as we develop all the things that we're doing, are we including what is the baby experiencing while all these things are happening? So that actually brings us to our next principle.
All right, our third principle, processes matter. So the way in which we do things, the way we go about what's happening when a baby and a caregiver are in our care are really important and can have a direct impact on that experience for everyone involved, right? And then depending on the caregiver's experience of that process, then that directly impacts the baby as well. So we have kind of 4 key points to think about with this area. How can we envision our processes as mechanisms to foster infant mental health? There's 4 ways we can go about this. The first way is understanding the family story. So knowing where the family is coming from, what their current situation is, any sort of history that might be helpful, identifying risk and protective factors, just listening and maybe knowing things about the members of the family, who showed up today, who didn't show up. Is this a family member that normally comes in with this baby? So just understanding the kind of family dynamic and what that looks like. Are there 2 caregivers that aren't currently living together? What does that look like for the family? And then holding the baby in mind. So helping caregivers to understand what baby's telling them, what they're trying to tell us as their provider, and getting good at explaining child development in kind of plain words that make sense. I know sometimes we use all these technical words and acronyms, and they can just, sometimes I get confused with acronyms too and trying to keep track of all. There's so many depending on your field, but how can we talk about this in plain words of what baby's seeing that caregivers can understand? What could baby be hearing? How does the child experience their world, and what does that look like? Or how do they experience their caregiver or us as their provider and what that looks like? And then thinking about the parallel process and professional use of self. So this is where that reflective process comes in, reflective practice. So what do we know about ourselves? How does that influence this child, the caregivers, my team, the environment with which I work? We all feel things. We all come into these rooms and these environments as our full self with our worldview and our lens and all the experiences that we've had, both professionally and personally. And what does that look like in these rooms with these babies and caregivers? And then thinking about reflective alliances. Who do we connect with? Who are my hands that hold me? And where can I go when I'm having true feelings that may feel difficult in the moment? How do I process this hard stuff, and having that supportive environment to lean into? Another aspect of this process is taking a moment to think about the patient journey and reflecting on what babies in your care may be experiencing when they walk into your office, what the caregiver is experiencing. So kind of some questions to keep in mind with regard to patient's journey. What is it like to be a baby in your care? Keeping the baby in the room and checking back with their experiences, being attuned to that, considering the family's journey, what it took to get them into your office that day, depending on what's going on in their lives at that time, and considering the caregivers and how they experience having their baby in your care. Body language can be a big cue with this. If you're asking the caregiver questions, are they open to answering them? Are they yes, no answers? Are they closed off? Arms crossed, arms open, and how our body language impacts that as well. Other questions we can ask ourselves. What do they hear when they come into the office? What does baby hear? What does caregiver hear? What's the lighting like? What time of day is it? What sounds might they hear? And maybe for a newborn, how's the parent recovering? How's mom that just gave birth to this child doing? And all those types of questions. And another thing that I mentioned earlier, but really considering who's coming to these visits, who's absent, why are they absent? What's maybe going on there? What's a story there that could really open this patient up with the limited time that we know you all have, but what information could be helpful to really know what's going on with this baby that's in our care? All right, so some practical strategies for processes. This is another quote from Jeree Paul, which is, how you are is as important as what you do. That's that idea of that reflective practice, and that we bring our whole selves into these rooms, and how we are and how we interact through these processes is so incredibly important. So some ways to think about that and some practical strategies are identifying ways to recognize staff, their roles, their accomplishments, really having a positive, healthy environment for our staff to be in. So that way, when they bring their whole selves in this room, they're in a healthy space to go into that room with that patient. And also providing means for exploring challenging interactions, having space for staff to discuss something difficult that might have come up. Maybe there was vicarious trauma. Maybe a patient reported something really difficult that had happened to them, and that sits heavy with us for a multitude of reasons, because we ourselves have experienced that, or because it's really hard to hear about someone going through something really awful and traumatic, and we're human beings with natural empathy. We're going to feel some kind of way, right? Another method is encouraging perspective taking and wondering, utilizing curiosity as a skill, and leaning into that. Sometimes biases and stereotypes can come up when we see parents and care and babies. So remaining curious of what's going on there. Maybe there's a reason behind certain interactions and things that come up. And last, but definitely not least, is reflection. When was the last time I was involved in a positive interaction? Sometimes when we've had a really hard day, it can be good to end or even partway through the day, depending on what's going on, think about, today has felt like a heavy day, but what was a positive interaction that I had? What was a relationship that I built today? Because infant mental health is really relational work, and those relationships are at the center of it. And when you had that positive interaction, how did it feel? What conditions made it possible to have that positive interactions, and how can we get more of those conditions happening in our offices?
An important part of thinking about infant and early childhood mental health is really leveraging our community, right? That we work also in a community with others who can provide support, and that we all together are the ones who create this these lovely cups really for these babies to exist. And so if we can work in conjunction with other programs and other services, then that might be able to help our patients, especially once they leave our office. There's only so much that they might take with them, right? We have just limited time with everyone. And so how can we be really effective with what referrals we might make, or what other resources we might point families to? And so when we think about infant early childhood mental health, we kind of look at things through a few buckets, I guess. So one is this idea that there's the promotion of the development of healthy infant and early childhood mental health. Some of the services that these are specific to what we know is in existence in Hawaii, but of course this is a non-exhaustive list. But these are ones that we know for sure are in existence here. So these are all local types of programming. But the promotion, right, of healthy infant and early childhood mental health, right, it comes in our early care and education settings, our family resource centers. When we have, I know we have a lot of ages and stages questionnaires that many of our community partners do. And the state does have the HELE program that families could also access the ASQ online. So there's lots of developmental monitoring that can also assist in the promotion category, as well as the different touch points, right? I know that pediatricians are often a big resource for families, especially when they have maybe their first child, or they have some questions that that they really trust physicians to provide support for. And so all of those encounters with each and every one of you really are very critical to helping a parent to feel confident in their role as a parent. The next, we made this in a triangle, not because promotion would cover most children. And then prevention, we might see a few families who have perhaps a few additional, or I don't want to say additional, but they just have other factors that are happening in life that might make it so that they could benefit from additional support. So we do have programs that are home visiting based, as well as center-based, or so we do have Parents as Teachers, there's Healthy Families America, there are family child interactive learning programs, there are people trained in the circle of security. So those might be some resources for you to provide if you are getting the sense that, hey, this family maybe has a lot of stress factors going on, or have told me about certain situations, like maybe, you know, they've had to move frequently, or they are leaving a volatile relationship. So these are families who could perhaps, you know, be at a little bit of a higher risk for potential disorders in the future. And so how can we mitigate that up front, right? How can we prevent those things from happening? And so those are just a few resources. And then at the very top, where we have what we hope is a small percentage of the population, will be children and caregivers who might need additional support. And when we talk about infant early childhood mental health, we really look at that intervention as being a dyadic intervention. And so when we talk about these three models in particular, child-parent psychotherapy, attachment and biobehavioral catch-up, as well as parent-child interactive therapy, what's unique about these three models is that they all have work with the parent or the caregiver and the child together. So it's different from some other models where there might just be a focus on, say, the child, or there might also be some other things like adult mental health therapy that might just focus on the adults. So say a mother has postpartum depression, or actually a father has postpartum depression, you know, they might seek a mental health therapist that's trained in adult mental health. That's lovely. And we could also give them support for how to work through that, or work with that at the same time as being a parent raising a young child, right? And so these three models would include the parent and the child together. And in child-parent psychotherapy, the way it's framed is the child is not the client, the adult is not the client, it's the relationship that's the client. And so when Dr. Tronick spoke about the repair that needs to happen, right? There are traumas that will happen, and we can't have a life or a world where there are no traumas. That is part of being a human. And so how can we then, like, knowing that can happen and will happen, how can we then buffer the impact of those trauma when they do happen? And so child-parent psychotherapy and attachment and biobehavioral catch-up and PCIT, they all work at helping with this parent and child repair the safety and security of their relationship. And that's why these three models are really looked at as best practices in infant and early childhood mental health intervention when there have been identified areas that need to be supported. Okay, so I hope that was clear. And so what we are hoping is that as a clinician, that you might learn about and refer families to some other to these evidence-based models that do support the dyad, right? The parent and child together, the caregiver and child together. How could you also have a team approach to care, right? What is the communication in your team? How do you work together in supporting the family in your care? And supporting one another also, just as Anne-Marie shared, when there's a lot that you learn about a family, even in just being in the same room as them for a few minutes. Sometimes families are just ready to say something, and you are the person they say it to. And so that can definitely be a lot. And also, how can we view caregivers as experts in their experience, experts in the child's life, and that they are an invaluable resource to you in terms of helping this child develop healthy, both physical, emotional, and that these caregivers are in need of support themselves, right? That we do, like I said earlier, if we care about the babies, we need to care about the adults who care for them, right? So how can we communicate that care with the limited time we have? And then hopefully engage with a mental health consultant who might be specialized in understanding the specific needs of infant early childhood. Development happens rapidly in that 0 to 5 timeframe. And having a mental health clinician who really understands the nuances of the different ages can really be beneficial to you in providing support and hopefully referring to additional services if needed. Okay. So with that, our review for today, we did define infant mental health and how it applies to the medical field. We also talked about strategies to identify how to implement infant mental health into the medical practice, and also ways to collaborate with community partners, along with identifying some resources that could help and support infant early childhood mental health. So with that, I think we can allow some time for, here's our contact information in the event that you had additional questions or you wanted more information. And we can, I think, close for some for questions, or I'll turn it over to Dr. Maxim.
And I can go
Or
ahead and
Summer.
do a poll.
Oh yeah, do that first.
Thank you, Erin and Anne-Marie. So we'll give everyone some time to answer the questions, as well as wait for any questions in the chat.
So folks, don't be shy while you're answering the questions. If stuff is popping into your head, there are no dumb questions or no questions that are not appropriate for this, you know, whether it's something that you've dealt with in your practice or that you are worried might happen, or just a practical aspect of like some of those changes that Erin and Anne-Marie were talking about, like how to implement them. Please feel free to drop those in the chat. We'll give you a little bit longer to work on the poll. And then I also had a question, but I'll just hold off until we get a chance to finish the poll. Summer, I accidentally closed the box with a poll, so I can't see how many people have answered. How are we doing?
We're about 65%.
Okay, so we'll give you guys maybe about another 30, 45 seconds. And then depending on how the answers are spread, if they're anywhere people don't seem to be super confident about the answers, we can ask Erin and Anne-Marie to go over those.
Looks like number 1 and 3 have some variant answers.
Would you mind going over those, one of you?
question number 3. Okay, the one about child parent psychotherapy, right?
1 and 3, so both of
Oh,
those.
1 and 3, sorry.
Mhm.
Okay. All right, so 1, let's talk a little bit more about that. So infant and early childhood mental health is really based on attachment theory. And that is really looking at the child and the relationship that child has to their caregiver. And Freudian psychology, as well as behaviorism, Freudian psychology does have some pieces of like early childhood. However, it's not based on the relationship, the quality, I guess, of that relationship necessarily. I don't know, Anne-Marie, if you want to expand more. I'm maybe not explaining it too well, but
Yeah, I think at its core, it's just about the relationship, and attachment theory is based on how we develop our first relationships, and that impacts our relationships throughout the rest of our lives. I could see why people would answer Freudian or behaviorism, though, because like Erin was saying, there's little aspects of um, the id, the ego, and these developmental stages with little ones where you could definitely identify some parts of infant mental health. But I would say at its core, it's with that attachment theory because of the importance of relationships. So if we just remember relationships and we looked at all these, it would help us point to attachment theory because of that. But I can definitely see why those other ones would come up for people.
and then I think too, like a lot of work around behaviorism really can take some of the emotion out of things. When we look at things strictly from a behavioral standpoint. And when we talk about like classical behaviorism, right, we're talking about and operant behavioral theories. It's very cause and effect, or antecedent in the behavior. And it's a little bit, infant mental health framework is a little different than that. The behavior doesn't, the important part is really uncovering what the potential reason is for that behavior that we're seeing. And that sometimes what we're seeing is actually not caused by whatever that antecedent was, but perhaps some underlying cause based in relationship. So yes, there are lots of pieces of it. And I guess attachment theory in a lot of ways kind of founded on the background of those theories existing to begin with. So that's probably part of it too. Okay, and the third one is about child-parent psychotherapy. So let me share my screen again, only because I think the visual is helpful. So when we talk about intervention versus prevention, intervention is when we have a relationship or a child who we have identified as needing additional, or I should say intentional support in repairing that relationship. So examples of some children who might be in the category of an intervention might be a child who has experienced domestic violence, for example. It could also be a child who's maybe experienced a death of a family member. And now all of these trauma that I'm saying are fairly, I would say, obvious traumas, of like ones that we know are going to impact a baby's life. But the thing about trauma, right, is that it's really specific to the individual and whether or not they're able to metabolize that trauma. So the intervention is more related or more applicable to children who are experiencing not only trauma, but trauma is one of the things that they might be experiencing. And then for prevention is when we have more families who have what we call risk factors, right, or have experienced. So we might see families here who maybe are houseless, for example. So they have an instability of housing. they might be a good candidate for prevention-based service, where there hasn't been a rupture or a rupture in the relationship, in the attachment relationship, that is showing up in the behavior of the child. So I guess when we think about now think about the first question in this question. So if we think about it from an attachment point of view, right, we're asking ourselves, is the relationship stable and solid? Is the relationship between the child and the caregiver stable and solid? If so, maybe they benefit from promotion-based services. If there's some challenges to that caregiver being present, right, thinking of that still face experiment, if there's reasons why that caregiver might have difficulty being present, then we might find them in the prevention category of needing some preventative supports to prevent that relationship from being in danger. And then an intervention is when there's kind of like a known rupture or a known issue in that attachment relationship, and would need some repair. So how can we work on creating safety for this child in creating a safe and stable relationship with their caregiver? So I think that might be my new way of explaining this. Anne-Marie, do you want to add? Because I feel like I might have been a little circular.
I just wanted to say that we do have a question in the chat. So if we can save well, it's 12:59, so could we, I personally think that was pretty clear. Sorry to interrupt, but I did want to see if you folks could maybe quickly answer Dr. Ware's question. He was asking what the nuts and bolts are of the services that you provide as AIM-HI.
All right, so for us as AIM-HI, I'll try to be brief. We hope to be the professional home for IECMH professionals in our state, and that includes all the people who work in prenatal to age 5. So we provide a lot of professional development. We provide infant and early childhood mental health consultation. And we also are working on systems work, helping to integrate policies as well that can be beneficial for littles in terms of their mental health. So for example, we do have a few training cohorts right now. We do have a cohort of child parent psychotherapists who are in training, who will be finishing up in about 6 months. And so we're working to build a workforce that can support infant and early childhood in our state. So that's our hope right now. So that was as fast as I could do it.
That was awesome. Thank you so much. And I'll have to hold off on my question for another day because it was so worth listening to that really clear explanation of like kind of how you parse out more specifically and concretely the 3 levels of kind of like prevention and treatment. And I forgot what the third one was, but like support or something like that.
Promotion, yeah.
Promotion, right. And so I wanted to really quick also remind everyone that we'll be doing the last of our PMHCA series next time. Dr. Yui Sarin-Karisate, who is one of our former residents and is now a developmental behavioral peds fellow on the mainland, will be talking about ADHD management. So I'm guessing that's going to be a really high yield topic, especially for the physicians in the group. I'm happy to stick around if folks do have any other questions. I don't know about Erin and Anderson and Anne-Marie. I want to be respectful of your time, but thank you for a really wonderful presentation that was so educational and also just reminding us of the human side of everything that we do and how the environment and just the way that we talk and the tone of voice and the body language and all those small things that sometimes can get lost are really, really important.
Thank you. I'm able to stand for a few more moments if that would be helpful.
Yeah, I can too. Thank you for having us. We really appreciate you all taking the time. We know you're busy.
Thank you. Yeah, lots of thank yous and compliments for the presentation in the chat. And I guess I'll just real quick, I don't see other questions, but what I was wondering is about how do you talk to parents about like phone usage? Because with the stone-faced experiment, it reminded me a lot of things that I witness all the time as a pediatrician in the hospital, which is this, and this, and not a lot of interactions. And I think, you know, especially when people are depressed or struggling, it's kind of a way to get those little, like, you know, neurotransmitter jolts that make you feel slightly better in the short term. And so I'm just curious, like, how do you talk to people about that, since it's such a like ubiquitous problem?
Such a good question. And sometimes when we describe the still face experiment, we talk a little bit about how that's one of the times when parents have a very flat affect. So I think practically, the question would, I guess it would depend, right, on the situation, if like you're seeing it in front of you or if it's just a topic that you wanted to cover. But I guess if you're, I know I'm thinking, if I were in the pediatrician's office, how would I want my pediatrician to talk to me about this? But
Yeah, not judgy, right?
yeah, right. Like, but just kind of really leaning into curiosity, right? Leaning into wonderings. I think that's a strength of how we do things, of just wondering. And I guess like I would want to once again understand the family story, right? Of like, what is it that you use to, how do you de-stress? Or when are the times where you find yourself really needing to disconnect? Because for some parents, especially if they're the default caregiver, right, can be really overstimulated, overtouched, auditorily, like when children are screaming all day, like, so they do need this ability to disassociate for a bit or dissociate for a bit. And so I'd be curious about like what strategies they have and what are some activities that they might be able to do with their child as opposed to separate from their child. And so I think my style is less direct, as Anne-Marie and I talk about things. I'm less direct, so I think I would personally go that route of trying to identify like the underlying reason why that parent might be using that phone quite so frequently, so that we can then perhaps come up with some strategies that might fill that need without it being the phone. And honestly, sometimes you can just show them this video and just say, what do you think? Is there a time where you think your face might, you know, okay, not like this, but like, is there a time when you think that your child might see that? And
I would
maybe they
say
come up with
sometimes,
it
oh no, go
themselves.
ahead.
No, that's it. Go ahead, Anne-Marie.
I would say sometimes we can practice speaking for baby too and leaning into curiosity of, I wonder what mommy's looking at on that phone. Or maybe baby wonders what mommy's looking at, and oh, looks like baby's trying to get mommy's attention. If baby's doing something and mom or dad or caregiver isn't paying attention, it's kind of a soft way to remind them, your baby's in the room. What does baby need and want right now? So I find that as a like little tip to lean in that maybe is like not judgmental and just kind of like curious, you know, and maybe mommy would show you what she's like, or, you know, tips like that can help lean into it too, and then bring the caregiver back into the room with you.
Thank you. I think those are great suggestions for not being judgy, but trying to at least like make a small impact. All right. Well, thank you so much for your time, your wonderful presentation. Oh yes, Renata, all of them like 7, 8 months old,
Oh
they
yeah,
can type an iPad.
they know better than I do how to use
Terrible.
those things.
Yeah.
Well,
But yeah, so thank you for a wonderful presentation and for coming back and teaching us again. We really appreciate it. And we hope everyone has a wonderful rest of their day.
Thank you.
thank you.
Thank you so much.
And Dr. Maxim, there's one other video that I was gonna say. I don't know if you guys, it went viral a while back, but it's this guy with his baby, like a father with his baby, and they're like sitting and watching a TV show, and he is just talking to this baby. Have you seen that video?
Yeah, like sitting on a couch.
Yes.
Yeah, I saw
And
it.
so like to me too, I think that's what I mean about like engaging the baby too, of just like, if you're going to do that, then do it, then how can we do it together? Right. So like, I don't know, I like that video in terms of like how a parent can like, they can still be an adult and be watching whatever they want to watch and still like include and encourage that interaction with their child.
Absolutely.
So not to cut it out, so to speak, but like, how can we use it in a different way? So
yeah, that's really great. Okay. All right.
Okay. Well, thank you all so much.
Okay,
Thanks, guys.
bye.
Bye.